Going to go over Chapter 5, cardiorespiratory and metabolic health. So now that we've kind of established the baseline of physical activity and public health and how those are related and the importance, we're now going to dive a little bit deeper into different categories of health-related issues and how exercise may affect those. So again, you have all kinds of objectives for each chapter. Some opening questions to think about would be, what do you think is the leading cause of death worldwide? Surprise, surprise, what it's going to be about. And then how much physical activity and exercise do people need to decrease their risk for things like cardiovascular disease? Lots of key terms to kind of get familiar with as you stay in the world of exercise and health, which a lot of you will. These terms will keep popping up over and over again because they are very likely things that you'll talk about with people. And so really kind of looking at this, we have this physical activity and all causes of mortality. And so mortality is, think about death, the things that cause death. When you look at it, research over a long period of time basically has indicated, and we saw this in earlier chapters, that avoiding inactivity, sedentary behavior, will help decrease your risk of dying from things. And we know that some activity is better than none, and the more that you do, the lower those risks are. So kind of a dose-response relationship. So the more activity I do, the less likely it is that I'm to die of certain things, if not all things. And so that's kind of what this chart shows. It basically shows your relative risk of dying prematurely versus the amount of activity you get in a given time frame, and you see that no matter where you look at it on the chart, the more activity you get, the less likely you are to die prematurely. The response or the benefits that you get are much higher when you go from none to a little bit, but even at the extreme levels, we do continue to see a decrease in your likelihood of dying early. So when you look at it, we talk about this thing, cardiovascular disease or CVD, which maybe you've heard about before, and it's really a group of different disorders that all affecting the heart or blood vessels that carry blood to our body. And so you have things like coronary heart disease. This leads to things like heart attacks that maybe you've heard about. Cerebrovascular disease leads to strokes, elevated blood pressure, which is called hypertension, peripheral artery disease or PAD. It's where the vessels in like our arms and legs are affected. Maybe they go numb, possibly even having to be amputated. Rheumatic heart disease, congenital heart disease, and even something called heart failure. All of these are wrapped up into, anytime someone talks about cardiovascular disease, putting all those together. We also have metabolic syndrome that we'll talk about, and metabolic syndrome is it's a cluster of characteristics is what it says there. It's a group of things that kind of you look at together that all kind of look at similar things and give us an idea of typically when you look at metabolic syndromes, the body isn't processing energy the way that we'd hope it would in the normal way. There's some issues with that, and that could lead to things like cardiovascular disease or other issues over time. And so these would be things like lipid levels, abnormal lipid levels. So you have something called HDL or high density lipoprotein. This is what people consider their good cholesterol. So if that's too low, you have things like triglycerides or LDL cholesterol, so low density lipoprotein. If these are too high, we know that can be bad. If you have trouble processing sugar in meals that you eat, or have improper insulin levels, again, if you have hypertension or excess abdominal obesity, so excess mass in your abdomen, all of these can be things that kind of lead or are metabolic syndrome. In addition to that, we look at diabetes. Diabetes is sometimes grouped in with metabolic syndrome. And so diabetes is, it could be that you have low insulin secretion. It could be the fact that your body doesn't respond to the insulin you make as well. And insulin helps to control the amount of sugar that we have in our bodies and our blood. So that's called glucose when we look at it in its basic content. And so there are two types. There's actually three types of diabetes. The main two you hear about are type 1 and type 2 diabetes. Type 1 is typically more genetically related. the body doesn't produce enough insulin. Type 2 typically is more related to lifestyle choices and is where your body doesn't respond to the insulin you make as it used to. Most people, if they say they have diabetes, most likely will have type 2. That's probably around 90 to 95% of cases. But those are there, and they kind of get grouped together because they're handled slightly differently, but they mean the same things kind of going on in the body. You're having trouble controlling those glucose and insulin levels. So when we look at it, we'll start talking with cardiovascular disease. Realize that cardiovascular disease is the number one cause of death in the entire world. Doesn't matter where you go, the number one cause of death is cardiovascular disease, and it really groups all those things together, but they all typically are the same things that cause them. They just happen in different locations of the body. So WHO, anytime you see that, is the World Health Organization. They basically in 2015 said 20 million people died of cardiovascular disease. The American Heart Association estimated that cost the United States $316 billion in the years 2012, 2013. And in the same time frame, cancer only cost Americans $81 billion. And so you can see that there's it's much above that. A cardiovascular disease is a much, much bigger problem than cancer is, and cancer treatment is much more expensive than cardiovascular treatment, and so you can kind of see the disproportionate of those. So when we look at it, when it comes to cardiovascular disease, there are things that put us at risk for cardiovascular disease that we may have control over. So we call those modifiable risk factors. So these are things like hypertension, so high blood pressure. We have control over this. There are things from our diet to exercise that can help with hypertension. Sometimes it's genetically related, and so we have some medications that can help with that. As long as you're not having high blood pressure, no matter how that correction is made, that's going to lower your risk for cardiovascular disease. Now, we'd prefer to see it through lifestyle choices instead of medication, but a lot of people just don't give those a shot, and so the medication's there to help to try to prevent things like heart attacks. That dyslipidemia, so having those cholesterol levels off with metabolic syndrome, we know that increased levels of cholesterol can lead to cardiovascular disease. Tobacco use is one of the biggest leading causes of cardiovascular disease still, and that is smoking and smokeless tobacco. It would include, in my opinion, marijuana and vaping and e-cigarettes. There's not as much data on that, but definitely is leaning towards that. Being inactive leads to cardiovascular disease. Being obese, again, metabolic syndromes are there. Having diabetes is a risk factor, but with diabetes, if you control that, so if you do what your doctor asks, you take certain medications, you kind of monitor your sugar levels and look at what you're eating, those can be kind of reduce those risks for cardiovascular disease. And then elevated inflammation biomarkers. So there are certain things we can look at in the body that look at inflammation or swelling in your kind of your internal organs, and if those are elevated, those can lead to cardiovascular disease over time as well. And so if we have things that put us at risk for cardiovascular disease that we can change or are modifiable, we also have some that are non-modifiable or we can't control them as easily. And so these would be things like age. So your age actually makes a difference. This is a disease that takes many years to develop. And so the older you are, the more likely it is that cardiovascular disease will be something that affects you more. We don't have a way to reverse that quite yet, I guess. Maybe one day there will be. But we see cardiovascular disease starting to develop in kids as young as 5 and 6. And then if someone lives to be the age of 80, they've had a disease growing inside of them for 75 years. And so we can see how that can play a role. But by no means does it mean because you're young that you can't suffer from cardiovascular disease. There are kids as young as 12, 13 that are having heart attacks because those modifiable things that we just looked at were way outside the normal spectrum. Your sex makes a difference. So we're talking about your XY chromosomes here. What was going on at birth, the sex you were born at. Realize in usually at least my world and typically the healthcare world, sex, male, female, how you were born, XY chromosome. Gender is more how you identify. So when we say sex, we're meaning kind of that how you're born. That does affect how your body responds. And males are more likely to have cardiovascular disease. your heredity or your genetics, what you got from your parents, and then your race and ethnicity play a role as well. Um, so you have to look at all of those things. Africans, especially those from Africa, but African Americans as well, see very high rates of cardiovascular disease, where Asians might not see as high of rates as cardiovascular disease when you look at those particular statistics. So here's a fun little chart that you can, I think we looked at this maybe on another one as well. And basically what you see here is intense exercise for two different people. People who are in the red are well trained. They've been doing exercise. Someone in the blue has not been exercising very much. And you see that we have this thing called VO2, volume of oxygen consumed. It's a measure of basically how much activity you do and how well you perform activity. It gives us a good measure of how well your heart and lungs can work to produce energy when you're active. And so the person who doesn't train has a lower VO2 max, which means their body isn't as capable of making energy and utilizing energy and moving blood throughout their body and moving oxygen. There's a lot that goes into that. Where in the red line, the person who's trained, that's much higher. They were able to go much faster on a treadmill, and that would be kind of that dose response. The person in the blue would have much higher risk of cardiovascular disease than the person on the red line. And so it's kind of looking at those particular things. Another thing we'll look at when it comes to all of this training is what effects are happening. So when you exercise, there are changes that happen in your body, and we're looking at graphs that show that as to why maybe it helps lower your risk for cardiovascular disease and your causes of death. And so what you see here, again, red is after you've trained, after you've exercised for a while. Blue hasn't done much of it. Bottom is treadmill speed. And then on the y-axis is what's called stroke volume. Stroke volume is how much blood your heart actually moves every single time that it beats. So your heart beats and it moves blood through your arteries, and so you can measure that. And the person who has been training, their heart is able to deliver more blood at every single speed on the treadmill, which allows them to go at a faster speed, and their body's not having to work quite as hard at some of the lower speeds. This is really good because when we see this stroke volume, what it means is changes are happening inside of our heart. Our heart's literally getting stronger, just like any other muscle would. And the stronger our heart is, the more likely we are to prevent things like cardiovascular disease. We then have changes in heart rate. And so what you can kind of see here is pre-trained, post-trained. There is really, especially down here, they're very close to the same. Very close to the same. So no matter what speed they were at, the heart rate was very similar, which is a good thing. Our heart works just as fast at every kind of given speed, whether we're trained or untrained. As we get towards the bottom half or the faster speeds, we see that there is more of a separation between heart rates. The person who's been trained, their heart isn't beating as fast because it's able to deliver more blood with every single heartbeat. They were able to go a little bit faster on that treadmill, and they never actually reached the same heart rate as the person who was untrained. And this is because their body was able to, basically other systems in the body gave out before the heart did. The heart still had some room to go, but it didn't need to because other systems couldn't keep up. And so when we look at it, we're really all about trying to prevent cardiovascular disease. The reason we look at this exercise is not to, just to have this information or not to force it on people, but it's really trying to prevent them from getting sick in the future with cardiovascular disease. And so when we have this secondary prevention, what we're looking at here is someone who maybe already has cardiovascular disease or has the early signs and symptoms of cardiovascular disease, and we're trying to do things to help prevent it from progressing or from getting worse. And so that's what this is looking at. There are 3 phases in this. Acute patient, so that's kind of looking at someone in the hospital or at their doctor's office getting some treatment. And then phase 2 is the initial 4 weeks kind of after they get out, where they're doing some very light activity. Maybe they're going to a hospital to actually work out. There are systems for that. And then from there, phase 3 is definitely greater than the 12-week mark, and could happen a little bit sooner than that. May not, depending on how the outpatient phase 2 goes. And so this is where you start building those patterns, those habits. They start progressing. Maybe you're going to a gym, working with a personal trainer, that type of thing. And when this system is followed, we know that someone who has had a heart attack is 20% less likely to have another one. It reduces it by 20%, and they're a quarter less likely to actually die from it as well. And so these are good things. Even late in the game, after cardiovascular disease already happened, exercise and physical activity can still help reduce those in the future. So when we look at it, there are many ways for us to kind of assess cardiorespiratory fitness, and cardiorespiratory fitness is what we look at in how much physical activity you've been doing and how well your body can handle physical activity. And this can be used to help us determine maybe some risk for cardiovascular disease or other different things. And it can also help us figure out if programs are working. Lots of good uses for this, and helps us just to track a lot of these things and to help prevent cardiovascular disease. And so there's a cardiorespiratory fitness function test. Those are out there, so don't get too much into those as much, but we do have common cardiorespiratory fitness measures, so those CRFs. So really everything on this list is one of those cardiorespiratory fitness function tests. They just measure it differently. And so what you're usually trying to measure is a VO2 max or VO2 peak, how much oxygen you can literally consume at a cellular level, so through your lungs, like how much oxygen can I breathe in from the air and use to make energy and use across my body. And typically those are done through exercise by working on a treadmill or a bike. And simply think about, if it was on a treadmill, you start kind of at a slower speed, and slowly that speed gets quicker and quicker, or the incline on the treadmill gets steeper and steeper, making the activity harder and harder. Your body's having to work more hard, and eventually we see the oxygen, you have to consume more of it, and we look for the point where you can't go any further and see how much oxygen you consumed, and that gives us a good indication of your cardiorespiratory fitness. This can also, the same kind of estimation or measurement of VO2 max can happen through distance running, so seeing how far you can cover in a certain time frame, or how quickly can you run a mile. It can be simple things like walking up sets of stairs, or biking for a distance, even swimming. And then there's even non-exercise tests that can be done based on maybe measurements from your body, so taking age and your resting heart rate and blood pressure, and you can look at things like that. Or even in a hospital, they can give you medications that simulate exercise and give an estimation on that as well. And so lots of ways to measure that, so that people can see where they stand and what their risk may be when it comes to this cardiovascular disease. What's really cool is we see that your VO2 can change over time. And so the higher that VO2 goes, typically the lower your risk are from dying, especially from things like cardiovascular disease or any things we talk about in this course. And we see that the intensity matters. So if you're inactive, your VO2 can change. It can go up and down a little bit. If you have low to moderate activity, or a little bit of moderate activity, we see that it goes up more than being inactive. A low amount of vigorous intensity, so you don't do a ton of it, but you are at a high intensity, gives you more benefit than doing it at a moderate level. And if you do lots of amounts of vigorous activity, we see that increase in VO2 increases a ton, especially from that of the inactive, reducing those risks for cardiovascular disease. And so there's a lot of scientific evidence that has gone into this. A lot of research studies have been done on this time and time again. And so basically what it looks like, if you look at all of it, is there is some really, really strong evidence that the more exercise you get, the higher the dose of exercise, the lower your risk of developing cardiovascular disease or other types of mortality, all-cause mortality, really. And it's unlikely to change, even if some study shows that it doesn't. We could have many studies, quite a few studies that show that this doesn't happen, but the evidence is so overwhelming that it would take hundreds, if not thousands, of studies to kind of back off of that thought, that the more exercise you have, the less likely you are to die prematurely of almost anything, but especially cardiovascular disease. And so that's a really, really good thing. We also know that when you're looking at it, moderate to vigorous, we know that vigorous gives more benefits, but moderate still is helpful. And we know that really, when you kind of put all the evidence together, we want to get about 150 minutes of moderate activity just to see those baseline measurements kind of level off and get to that, at least knock the majority or at least the big steep portion of those death risk away. And so, like I said, it continues here to talk about it. One of the things we know is that it doesn't matter your age, your sex, your race, or weight status. We know that this dose-response relationship with exercise and mortality risk is still there. The only thing we're not really sure about is is it affected by ethnicity or socioeconomic status? There's just not been enough studies done on it. But at the end of the day, we do know that it's a very good relationship and very strong for almost all cases across the board. This particular table is a cool table. It just kind of lets you see activities that are common for older adults, and children, and what activities kind of fall into the moderate intensity category and what falls into the vigorous activity category. Realize some things are dependent on how you do them. And so you see biking in multiple spots depending on how you do them. Some things that confuse people, a really good vigorous intensity, high intensity activity is jumping rope. If you don't believe me, go try to jump rope today and see how long you can do it before you're laying on the ground ready to pass out and not want to go on with activity. And so when we do look at these things, we can look at the economic cost of metabolic disease as well. So again, following along those same lines, we looked at the cases and how much it cost. We know that when it comes to metabolic diseases, many people have them. Over 1 billion people worldwide have those, and 422 million people have diabetes, which is related to that. We know that United States population has between a quarter and a third of people that have these metabolic syndromes. We know that it can vary based on genetics, age, and ethnicity, but we still know that's a lot of people. It cost the United States a tremendous amount of money. When you look at it, you can kind of see here these statistics on type 2 versus type 1 diabetes as well. And what's an even crazier thought is, now this is all the way back in 2005, but diabetes was one of the leading causes of non-traumatic lower limb amputations. So what we're talking about here is people having their legs amputated in some form or fashion, maybe just at the ankle, maybe all the way up to the hip. But typically when you think of a amputation of a limb, something traumatic's happened. Maybe a car fell on it, you got ran over, some kind of accident. But 60% of non-traumatic, meaning that nothing just all of a sudden happened, it was things over time. 60% of those happen because of diabetes itself, showing you that it causes issues with the blood vessels. And so you can also see here the reason that diabetes is talked about more and more is that in the course of 20 years, from 1994 to 2015, the rates of diabetes in the United States went up a lot. We went from, when you look at kind of the coloring, maybe around 4.5%, 5%, to when you look at 2015, you're closer to the maybe 8% mark. So almost doubling in 20 years how many people have diabetes. And so that's a reason that this is talked about as well. You can see the trends. Table 5.2 is really good to kind of look at. As you stay in this, it kind of shows you what is the criteria for these, for someone to have a certain measurement that would be considered metabolic syndrome, or that this is outside of the normal. So what you're really kind of looking at, we'll focus on the first one. So fasting glucose, the last one, fasting glucose is how much sugar's in your blood when you haven't eaten anything or drank anything in 8 hours. Well, if you take that measurement, it's through taking a blood sample. If they measure that you have less than 100 milligrams per deciliter of blood glucose, so you have less than 100 milligrams of sugar per deciliter of blood, you're considered normal. When it's over 100, you'd be considered to start having metabolic issues with your fasting glucose. Now, one measurement, that happens and it's just above, your doctor's not going to be concerned, but it's multiple measurements that are well above 100 that would start to concern them. You have things like blood pressure, HDL cholesterol. So if your good cholesterol is too low, that could be an issue. If your triglycerides are too high. So it's just kind of showing you those measurements that there is an actual number that's kind of a line that looks like, and you'll get familiar with these as you move forward, especially in the healthcare world. These numbers keep popping up over and over because they're measurements of not only cardiovascular disease, but of general health and other things as well. And so you have all of that going on. When it comes to metabolic disease, we have risk factors just like we did for cardiovascular disease. There's more of a family history of diabetics that can look at that. Family history of diabetes does connect to diabetes pretty well. Ethnicity and race makes a difference, and we kind of summarized this a little bit, saying Hispanics, African Americans, Asians are at higher risk, even Native Americans. We know that if you're more sedentary, that you're more likely to have metabolic disease. And if you have a history of cardiovascular disease, more than likely you have metabolic disease, and it just may have never been diagnosed. So, so we're looking at all those, and we're starting to get that picture of why those things are a big deal and kind of how exercise is related to that. And so when we start connecting metabolic health and kinesiology or movement, certain things happen when you become physically active that kind of help with metabolic health, help improve how your body processes energy and your risk for these things. And so we know that when you're physically active, you burn more calories, you expend more energy, and this helps to make sure that your body doesn't have too much energy, because if your body has too much energy that it can't utilize, it starts trying to store that, starts trying to figure out what to do with it, and that's what throws a lot of these cholesterol numbers and hypertension and obesity out, outside of the norm. We know that you start to synthesize protein, so make proteins in your body. Your muscles made up of protein, and so your body takes amino acids, the building blocks of proteins, and builds them. And so you become better at that. You become better at absorbing the protein and utilizing the protein you consume, and this helps, again, with that metabolic health. You help to reduce those low-density lipoproteins. You help to reduce the bad cholesterol, and you help increase the high cholesterol, or the good cholesterol, the high-density lipoproteins. Same thing, you reduce triglyceride levels, and you actually improve your body's ability to be able to process and utilize sugar or glucose in the body, so that diabetes measurement, when you exercise, your body actually figures out how to use that glucose the correct way and how to use insulin in the most efficient way. And so that helps to lower your risk for diabetes. And activity can actually help people that already have diabetes to help control that better, less through medication and more through, again, lifestyle habits. This is another chart that just kind of shows the same thing we've been talking about, except this time we're looking at type 2 diabetes. And this is 4 different studies that all kind of looked at activity levels, and this kind of gives you how they measured those METs, hours per week, and kind of lets you know low, moderate, high intensity. What we really see is the relative risk for type 2 diabetes, even with just a little bit of activity, starts going down tremendously, and the more we do, the lower it goes. So when you look at metabolic function, they test for blood, they test for cholesterol. What is on this screen right here is really talking about looking at diabetes measurements more than anything, but can look at other metabolic issues as well. You have fasting plasma glucose. This is where you don't eat or drink for 8 hours. They take a blood sample and they measure how much sugar is in your blood. They also have an oral glucose tolerance test. This is where you come in to a doctor or lab, whatever, fasted for 8 hours, so you haven't eaten or drank anything for 8 hours. They give you this really sugary drink, like it's tremendously sugary. You have to drink the entire thing in a specified amount of time, and then they measure your sugar levels in your blood over the next 2 hours. And so what happens when you do that in a normal person is you see a spike in that glucose number. You see the sugar in the blood goes way up, and then over the course of an hour after you consume it, 2 hours, you start seeing it decline and usually getting back below kind of your resting values by the end of that 2 hour mark. Someone who has trouble processing glucose for metabolic issues, what you see is you see that number go up, and you see it maybe doesn't go down over the course of 2 hours or goes down very little. You can then like test plasma glucose randomly throughout the day, like just a random sample to see where things fall. And you can look at that throughout the day and see how it responds after meals and that type of thing. And then the final one that you may hear about is HbA1c. HbA1c is a way of looking kind of at how your glucose levels have been over the course of the last 3 months or so. It's more of like a long-term method. So I could easily affect my fasting plasma glucose with some exercise a couple days before I had that measurement taken, even the morning of. But HbA1c would let the doctor or anyone know how has that person's kind of glucose processing and glucose utilization looked over the past number of months to give more of a long-term picture than just that short-term picture. And again, you can see here another thing that just shows the dose of exercise compared to the risk of metabolic syndrome. Low levels of activity, high risk, more activity, and each one of these are different studies. Study after study after study has shown this same dose response relationship. Again, here's one on long-term physical activity levels. So if we look more than just short-term, but risk of developing metabolic syndrome with long-term physical activity levels, so looking at months or years, we can see that that's much lower as well in multiple studies. And again, the scientific evidence for this is just like with cardiovascular disease. Basically, the more physical activity you do, the lower you are for your risk of type 2 diabetes. Doesn't necessarily reduce your risk for type 1 diabetics, but can help lessen the symptoms that you have from that when you look across it. Again, we know that vigorous can play a bigger role than moderate, but any activity is going to be good. And so we're always encouraging more of that, and it also helps to reduce your body weight, which can help reduce type 2 diabetes. And so there's limited evidence to indicate that this could be influenced by age, sex, race, ethnicity as far as the exercise response to these things. We know that certain races may have higher risk for type 2 diabetes, but we're still seeing that physical activity across most races tends to decrease that. There may be some evidence not showing that. We just don't have enough to say, but we're pretty confident that the more exercise you do, the less those risks are, almost regardless of who you are. Let's see, we're not really sure about how physical activity and socioeconomics and type 2 diabetes go. So we can see that there are some holes, but again, we see that there's a similar pattern, at least, to all the evidence that we have. Table 3 shows you of those of the fasting glucose measurements that we talked about, kind of where your results fall. You can have sugar that's too low. That is a whole different disease called hyperglycemia. But you can kind of see here what those measurements look like for what's called a pre-diabetic or having too high of blood sugar. There's too low, hyperglycemia, and you have very low. So if someone's blood sugar gets too low, they actually become unconscious. And then also an HbA1c level, kind of just showing you if you have those results your own, maybe you get those this semester, you can kind of look for yourself and see kind of what the typical classification is, but always look to your doctor for guidance. And so that kind of sums up this chapter of showing that dose-response relationship and how it goes physical activity with cardiovascular disease and diabetes and metabolic disease. Look at your book and make sure that you kind of look at some of those resources. They're really good. And let me know if you have any questions.